Today we will be talking about shoulder and elbow problems and the most common conditions that we'll see in each area. We're going to start with a focus on shoulder anatomy, then going over rotator cuff injuries, glenohumeral arthritis, lateral epicondylitis, and then we will cover therapy protocols after that. As you see with the image on the right, this is an image of a typical AP, which means front to back shoulder x-ray. And as you see on the right of the screen, there's the humeral head. On the left is what we call the glenoid. And this is kind of the typical ball and socket that some people will refer to in the shoulder. Another key component there is the acromion, which is right above the humeral head. And often that can play a part in certain rotator cuff or impingement type pathologies. So the anatomy of the glenohumeral joint can be thought of as a golf ball on a golf tee. And as you see here, you have a very big golf ball sitting on a small golf tee. And without other types of constraints in the shoulder, that golf ball would easily fall off of that golf tee. And so within the shoulder, you have static stabilizers and dynamic stabilizers. The static stabilizers include your glenohumeral ligaments, your glenoid labrum, and your capsule, whereas your dynamic stabilizers predominantly involves your rotator cuff muscles and also your scapular stabilizers. And all of these in combination help to keep that ball on top of that golf tee. The static stabilizers, as you see here in this image, primarily encapsulate or cover the shoulder and is something that helps to keep it in place. And then on the picture on the right, you see the glenoid labrum, which can often be torn in certain dislocation type events. Here's another picture of the labrum. You can see on the left there. And what the labrum does is thicken the depth of that ball and socket articulation and makes it more difficult for that humeral head to go out and to move and dislocate. And you can see that same image on the right. This labrum is basically, you can think of it as a bumper, kind of like where you have bumper cars to keep those cars on the track and from moving outside where they should be. Dynamic stabilizers, which will be a main focus of our talk today, are the rotator cuff tendons and muscles. And as you see there on the left, on the front picture, you have the subscapularis. The rotator cuff tendons are a combination of 4 tendons, and you have the subscapularis in front. You have the supraspinatus tendon, which is on top on the right picture, and in the back you have the infraspinatus and the teres minor tendon. Why are these stabilizers important to lift the arm? Well, these stabilizers are important because of the deltoid muscle. And this picture here is a big picture of a deltoid muscle, and you can think of the rotator cuff tendons as being kind of all about the deltoid. Those stabilize the ball and socket joint and allows this big, strong deltoid muscle to lift your arm, which is also why in certain conditions, injuries to some of these rotator cuff tendons with proper rehabilitation can still result in adequate function to the shoulder, because if you have a balanced shoulder, the deltoid is still able to lift the shoulder. And here again are the rotator cuff muscles. You can think of the acronym SITS, which stands for supraspinatus, infraspinatus, teres minor, and subscapularis. And the predominant motions that each of these muscles and tendons assist in are also shown there. So the supraspinatus helps with abduction or elevation of the arm. Infraspinatus helps with external rotation or moving the arm out to the side. Teres minor also helps with external rotation, but that's going to be more with the arm up here and helping to provide and stabilize this motion. And then the subscapularis primarily helps with internal rotation of the shoulder. So let's talk about some pathologies in rotator cuff tendonitis and subacromial bursitis. This is not associated with a rotator cuff tear, but is instead associated with a result of compression of the rotator cuff muscle by superior structures. These include the AC joint, the acromion, the CA ligament or coracoacromial ligament, which you can see in the picture to the right, which leads to inflammation and development of bursitis in the shoulder. You can imagine that acromion on the top, if that somehow you develop what's called bone spurs on the undersurface of that, or you have an acromion that's thicker than normal, when you go to move your shoulder up, you can imagine impingement and pinching of your rotator cuff tendons between that acromion and your humeral head. This can result or be the result of acute trauma or chronic wear and tear or chronic tendinopathy. This diagnosis can be made on physical exam, with a positive Neers or Hawkins test. Now that's when you raise your arm up or you raise your arm in and you have significant pain in your shoulder. And you can imagine with these type of motions how this would result in pinching of that humeral head against that acromion. This exam and this diagnosis can also be supplemented with MRI studies. So treatment for tendonitis and bursitis. With tendonitis and bursitis, there's often a trial of non-operative measures, including NSAIDs, or non-steroidal anti-inflammatory drugs, physical therapy, and corticosteroid injections. If these fail, arthroscopic subacromial decompression with an acromioplasty, which is where you actually shave down the bottom of that bone, seen in the picture on the right there, can be indicated in patients who fail conservative measures. But I would say the mainstay for any type of tendonitis or bursitis is non-operative measures, and the majority of patients can get better with conservative care. The next thing we'll talk about today are rotator cuff tears. Supraspinatus tendon tears are the most common, and this is the top rotator cuff tendon. This can often be due to either acute trauma or a chronic wear and tear type pattern from a chronic tendinopathy type picture. Treatment is also based upon age and activity level. In young, active individuals, this usually requires operative treatment, especially in a full thickness tear, whereas a partial thickness tear or a full thickness rotator cuff tear in older, low activity type individuals usually respond well to non-operative treatments, including non-steroidal anti-inflammatories, steroids, and physical therapy. As mentioned previously on the anatomy slides, the deltoid is the primary elevator of the shoulder. So if you have what's called a balanced shoulder and your front rotator cuff tendon, your subscapularis, and your back rotator cuff tendon are intact, then often with proper physical therapy, you can retrain the deltoid to be able to actively lift your arm. So how do you identify a rotator cuff tear? This is often by initial history and physical examination. So an acute traumatic injury, a fall, landing on your shoulder, injury on an outstretched arm can all be signs with continued shoulder pain and weakness that you may have injured a rotator cuff. This could be based on an injury, or it could also be seen with things such as night pain, and often this diagnosis is confirmed by an MRI. So we see you in office, you have a history consistent with an acute injury or a chronic injury, and then on top of that, you also have an exam that shows you have weakness with strength testing of these rotator cuff tendons. That in combination often results in the ordering of an MRI, which can confirm a rotator cuff tear. And David will go into rotator cuff tear rehab a little later on, but here's just a picture of some general strengthening exercises that are often used to help build up the strength of those small little rotator cuff tendons. And you'll notice this is different than your typical going to the gym, powerlifting, overhead type activities. These are mainly focused on these small rotator cuff tendons in order to provide stability for the shoulder. Now, if there's an acute traumatic rotator cuff tear or a chronic rotator cuff tear that does appear repairable, you often proceed with a rotator cuff repair. Now, the indications for a rotator cuff repair, as we've discussed previously, also are based on the MRI. Smaller tears and tears that have good muscle quality often do better and are more favorable for success with surgical intervention. Here's an image of a torn rotator cuff on the left and a repaired rotator cuff on the right. The space that you see below the white part on the left image is actually looking into the glenohumeral joint or the ball and socket joint. And that is actually the humeral head in the middle of that picture. And then this rotator cuff tendon actually attaches to the bottom of the picture on the left. So what we do during surgery is clean off the tissue on the under part of that image on the left so that you have excellent bony area for healing. And then we take that tendon, we usually place anchors, and this is through an arthroscopic procedure, which means it's done through a scope and small poke holes through the shoulder. And we place anchors just off of your cartilage, and then we pass this suture through your rotator cuff tendon and then tie it down to additional anchors on the outside of your rotator cuff. And what this does is it actually compresses or smashes that rotator cuff tendon back down to bone where it belongs. And even though we have repaired this tendon, it still takes 6 to 8 weeks for that tendon to really start scarring down to that bone, which is why in physical therapy we start with just stretching, and then after about 6 weeks we have you start lifting your arm on your own with the help of your other arm. And it's not usually until about 2.5 to 3 months that we start even strengthening of this tendon, because we have to wait for it to heal prior to starting a strengthening program. So here's that rotator cuff repair recovery that was discussed. We usually keep patients in a sling for 6 weeks. We start therapy 3 to 5 days after surgery with passive motion, which just means somebody else taking your arm or you taking your arm and stretching it up. And then active motion, which is starting with active assist motion, where you're helping your shoulder and lifting it before you're ultimately lifting it on your own. And then strengthening for 6 weeks, which is again about 12 weeks or 3 months after your surgery. So it takes 6 to 8 weeks for this rotator cuff to scar down, which is the reason why we delay aggressive early physical therapy. The next thing we'll talk about today is glenohumeral arthritis, which is a wear and tear of that ball and socket joint. And as you see on this picture on your right, this almost has a cue ball type look where you have hardening of your humeral head and you have loss of cartilage. And then the picture on the left demonstrates that arthritis as well, with narrowing of that joint space. What are you going to see and what type of symptoms with glenohumeral arthritis? You're going to see a deep-seated pain going up and down the arm. You can also see weather-associated changes. So, winter's come on and now my shoulder's hurting me again. You can see symptoms of stiffness. You can have decreased energy due to chronic pain. You can have difficulty sleeping, and difficulty sleeping is common with a lot of shoulder pathologies. And that's because your inflammatory mediators are often elevated at night, causing an increase in pain. And then you can also have grinding or catching with movement. So your strength may be preserved, but you've noticed with time that you're not able to lift things high on a shelf anymore and that your general motion is diminished. Here's a picture of a normal shoulder on your right and then an abnormal shoulder on your left. And as you see in the middle there, these are not equal. You can see on the left side there is what we call a goat beard deformity, which is a big bone spur underneath the humeral head. And then you can also see that there is some space between the humerus bone and the glenoid on your right. And then on the left, there is no space there, indicative of advanced glenohumeral arthritis. Now, what is the treatment for glenohumeral arthritis? The first-line treatment for this is actually non-operative treatments. These include things such as cortisone injections, physical therapy, anti-inflammatories, and oral steroids. And what I tell a lot of my patients is that the good thing is you don't walk on your shoulders, which means that people can actually do quite well with non-operative treatment with pretty advanced arthritis. An MRI or a CAT scan is often used based on x-rays to determine rotator cuff integrity and the degree of bone loss. Of note too, I will typically delay a shoulder replacement surgery by about 3 months after a cortisone injection. Some studies based on hip and knee literature have shown that there is a slight elevated risk of infection with a shoulder replacement performed shortly after a cortisone shot. So once we've identified that you have glenohumeral arthritis of your shoulder, we'll start with x-rays. And x-rays are always a start to the diagnostic process, and we get what's called an AP film, which is a front to back view, a scapular Y view, and then also an axillary lateral. And what this axillary lateral is the picture on the right, and that really shows the alignment of the humerus bone on your right and the glenoid on your left, and allows us to see if you have a lot of wear of that socket or that glenoid on the left, which can result in subluxation or kind of movement of that humerus bone towards the back. And if that is seen, you may need more advanced procedures or a different type of procedure altogether. So that's why x-rays are of utmost importance when diagnosing arthritis of the shoulder. So operative treatments, the general rule of thumb is that arthritis with an intact rotator cuff in an individual less than 70, we tend to prefer what's called a total shoulder arthroplasty, which we'll get into in a little bit. Arthritis with the presence of a rotator cuff tear or irreparable rotator cuff tear in an individual greater than 70 often proceeds with a reverse total shoulder arthroplasty. And these are two types of shoulder replacements that we have to offer patients. So what is a total shoulder arthroplasty or TSA? This is a replacement of the humeral head, which is metal, and the glenoid, which is the socket, with plastic. So we use metal on the humerus side, which you can see very far on the right. That's what the implant will look like. And then the middle image there is a picture of the glenoid component. So it's the metal and plastic, which gives you the image on the left. Now, a total shoulder arthroplasty, you do need an intact rotator cuff in order to stabilize that and allow that compression of that golf ball and that golf tee, because we have not changed the golf ball and the golf tee, so we still need those functioning appropriately in order to adequately lift your arm. Now, what if my rotator cuff is torn and I have arthritis? Well, then you need a procedure and an implant that helps to recreate those rotator cuff tendons and allow you to lift your arm. And this is called a reverse total shoulder arthroplasty. So this is an x-ray that you saw before, and you'll notice the image on your right is a normal x-ray of the shoulder, a normal AP film, whereas the x-ray on the left shows advanced glenohumeral arthritis with a goat's beard deformity, the narrowing of the glenohumeral joint, and glenohumeral arthritis is noted there. Whereas the next image, you'll notice this does not look the same. The image on the left was the one we saw previously compared to the image on the right. And the image on the right shows that now we have what's called superior migration of the humeral head, where that humerus bone is now up in relation to the socket there. And you actually start to see wear of that acromion bone that we learned about and talked about previously. This is consistent with a massive rotator cuff tear. The image on the left, I would not anticipate a full thickness rotator cuff tear based on the overall alignment of the ball and socket joint. Whereas the image on the right, I would anticipate a massive rotator cuff tear and the need to proceed with a reverse total shoulder arthroplasty. So going into a shoulder replacement, these are some diagrams of how the procedure is performed. And we use what's called an anterior approach or a deltopectoral approach. And we're actually going through the deltoid muscle, which you see on the picture on the left is the right to the right of the image on the outside. And then the pectoralis, which is shown there to the left of the image. And we actually split these two muscles and then go down to your joint where you see on the right. We remove the arthritic humeral head and replace this with either a reverse shoulder or a total shoulder arthroplasty. And here's an image of a reverse total shoulder arthroplasty. So you take the image on the left where you have superior migration of the humeral head, you have a massive rotator cuff tear, you have arthritis, and then we actually create what almost looks like a reverse of a hip joint where you have a ball and a socket type component. And what this does is it recreates the function of the rotator cuff muscles and tendons when they're not there anymore, and it allows the big deltoid muscle now to lift your arm. Outcomes of shoulder replacement. What can you expect with a shoulder replacement? So pain relief is going to be the most predictable outcome. You also have a reliable range of motion. And there's actually really good survival. At about 10 years, 93% of these are still in place. As obviously as you increase, that number does go down, but there's actually good longevity with both cemented and press-fit humeral components. So both of these procedures, the reverse shoulder replacement and the total shoulder replacement, both do quite well, and although they both do have their advantages and disadvantages. So key points to a shoulder replacement. As we have discussed, a total shoulder tends to favor individuals who are younger. You need a normal rotator cuff, you need a normal glenoid, and these do have low levels of complications and long survival. And I would say the total shoulder is it's an anatomic replacement, so it recreates the native anatomy, and you can probably expect a higher ceiling as far as your overall outcome, but you also do need rotator cuff tendons to heal. And something we didn't necessarily go into, but you actually have to go through part of the rotator cuff tendon in a typical total shoulder replacement. In order to have a successful outcome, you have to get that to heal at the end of the procedure, and that can take 6 to 8 weeks to heal. So actually you're in a sling for 6 weeks again, and it's a very slow recovery, but ultimately people are quite happy with a total shoulder arthroplasty. Likewise, the reverse shoulder replacement is often seen in individuals who are older, and it's used in cases of rotator cuff deficiency. Now you do need a functional deltoid muscle in order to work, and this can have higher potential complications. As I tell patients, if you do a total shoulder and this is unsuccessful, a reverse shoulder is always a potential option. If you do a reverse shoulder replacement and this is unsuccessful, the option is much more difficult and often includes a revision to another reverse total shoulder arthroplasty. And it's also newer, so less is known about the outcomes. A reverse total shoulder has only been in the United States since 2003, late 2003, early 2004. But the medium-term data has actually been quite good, and I think this is something that we will continue to promote and something we will do more frequently in the future because it actually has shown to be quite predictable and have very good results in the data that has been currently presented. So next we're going to move down to the elbow and go over the most common elbow condition that I see in office, and that's called lateral epicondylitis, or lawn tennis elbow. This was coined by Morris back in 1882. And lateral epicondylitis, how common is this? This is very common. Here's a study here going over the percentage of individuals who have lateral epicondylitis complaints. And as you can see there, it's actually quite high. A very large number of individuals throughout their lifetime will have issues with lateral epicondylitis. So how is lateral epicondylitis going to present? It's going to present as lateral elbow pain that radiates down the forearm. You're going to see pain with resisted wrist extension, as well as resisted finger extension here, and also pain with gripping type activities. This will often be seen in individuals who do a lot of typing and a lot of wrist type activities, and it's often due to overuse, chronic wear and tear type issues. So on physical exam, you're going to have point tenderness kind of right over the elbow. So people come in and they say, it doesn't hurt here, it doesn't hurt here, it hurts right here. And it hurts when I go to lift things, it hurts when I do activities at work, it hurts when I'm responding to emails. And these are all very characteristic of lateral epicondylitis. On imaging, x-rays are often normal, and there is a large number of tendons that attach on the outside of the elbow to a very small space. And so you have a lot of force going to a small area, and you also have a low area of blood flow. So you have blood coming from the top, and you have blood coming from the bottom of this image, and in between you have what's called a watershed area, or an area that does not have great blood flow. And this can often result in chronic issues that you keep injuring that has a lot of difficulty healing. The specific tendon involved is the extensor carpi radialis brevis. And this is a very small tendon that attaches to the outside of the elbow there in the picture to your right. And this is the tendon often involved in lateral epicondylitis pathology. Now, natural history, the good news is 80% of patients have symptomatic improvement at 1 year. And if you're outside of that window, obviously you're unlucky, but the majority of individuals do tend to get better with non-operative treatment. So will I get better? 82%, as we talked about on the previous slide, so just over 80% of individuals respond to conservative treatment and can avoid surgical intervention. So here's another slide that talks about the success rates of different types of treatments. 69% got better with steroid injections. 91% of individuals got better with physical therapy, but 83% of individuals actually got better with a wait-and-see approach. So this shows that actually wait-and-see was more successful than steroid injections on their own. I typically avoid steroid injections as a first-line treatment for this because there's often tears present, and while it may result in short-term improvement of symptoms, these symptoms often return and are similar to what they were before the injection. So non-operative treatment is the mainstay for this. Things such as therapy, corticosteroids, which we said only provide short-term relief, and we typically will avoid these in most situations. Anti-inflammatories, bracing, and what's called PRP, or platelet-rich plasma injections. And with that, what you do is you take a blood draw, and you spin this down in what's called a centrifuge, and then you take that center platelet-rich region and you inject it into that area. And it basically tells that tendon to start healing, and it provides these growth factors and healing factors to that region, and it's actually shown to have pretty promising results. The image on the middle is what is called a bandit-type brace. And what this does is it provides compression just distal or just below this lateral epicondylitis region. And what it does is it dissipates all these forces when you move your wrist that are coming up the arm. And so instead of centering on the elbow here, they now center on an area distal to that, and that can be a large improver of pain. So treatments for operative treatments, if you do fail non-operative management, you can proceed with debridement and repair. This term was coined by Nerschel back in 1979, which is actually what the procedure is named, which is the Nerschel procedure. And this includes an open debridement and release of the ECRB, which is your extensor carpi radialis brevis, which is often involved, and then decortication of the lateral epicondyle. The lateral epicondyle is the outside bony prominence here where this tendon attaches. And so you almost provide irritation to that bone there. And what that does is it provides an increased area for healing and allows blood to come in and allows this to heal and allows improvement in pain and improvement in symptoms. There's 80 to 90% satisfaction long-term at 5 years with this treatment. However, as we mentioned previously, the majority of patients can get better with non-operative care. So what are the take-home points of lateral epicondylitis? Lateral epicondylitis is often a self-limiting disease that will improve in greater than 80% of patients with avoidance of surgery. There is a variety of non-operative and operative treatment options. However, the mainstay should be non-operative. You also need to educate and set expectations to patients, which we often do. I tell all my patients that this is something that without treatments could last a year or two. It often gets better with non-operative management, but that it's something that could continue to give them issues for months and months down the road, and we hope to at least improve these symptoms with different treatment modalities. But there's no one right or wrong treatment for lateral epicondylitis. So thank you for joining us today and for listening to this talk on upper extremity pathologies. I appreciate your time, and I hope you got something out of this and were able to learn a little more about shoulder issues as well as lateral epicondylitis of the elbow. Next up, we have David Stepner, who will talk to you about physical therapy protocols for these upper extremity pathologies. Thank you.
Hi, my name is David Stepner. I'm a physical therapist with St. Elizabeth. I practice in Burlington, Kentucky. So I just wanted to talk a little bit before we get into the shoulder rehabilitation that Dr. Kohrs had talked about what physical therapy does. I don't know if everyone's been to a physical therapist before, but at St. Elizabeth, we take 45 to 60 minutes and we evaluate you and ask questions about your shoulder. What's wrong? How did this happen? What things can and can't you do? And then we take some objective measurements. We do our own physical examination, similar to the physician, but we do some other things as well. We do some outcome measures and some questionnaires. We do a lot of data collection in that evaluation. We do some palpation and measurements, and then we do our own special testing as well. The idea of this is to get a plan of care together for you, and we talk to you about what your goals are for physical therapy and what you want to try to accomplish with our care. Dr. Kohrs had quite a few slides on the anatomy, but it's important for the physical therapist to understand what's going on with your shoulder as well. So these are some slides that more graphics about what rotator cuff tendonitis and tendinosis and ultimately a rotator cuff tear is. We also have to know what's going on there as well. We don't always have the luxury of having an MRI, so we have to know the anatomy and what's happening with your shoulder, and we do that through our physical exam that I noted before. So rotator cuff tendonitis and tears, kind of the non-surgical approach. So from the evaluation, we find what deficits you have and the areas that need improvement. Those tests that we do tell us what's wrong with the shoulder, and we move forward from there. So we look at function, and we're trying to restore that function from the deficits that you have. So what a physical therapist does is we incorporate exercises and different forms of manual therapy, and of course education about how to move your shoulder to kind of help restore your function. So the specific education is very important. Specific exercises is very important. And it's not just like going to the gym or getting something off Google. We highlight things that are important to you specifically with the evaluation and move forward through a series of specific exercises that will help you. Now moving forward to the rotator cuff tear and the subsequent surgery that Dr. Kohrs does and his colleagues. We also have to know about what's going on there anatomically before we can treat you also. So we go through some schooling to understand what they do so we can help you appropriately. So the rotator cuff tears, treating those post-operatively. We do the evaluation very similar to what we do without surgery. We figure out what your goals are, what you need to do, and what problems you may be having post-operatively, hopefully few, but we try to triage those if there are. And then we use a very specific guidelines that are we find from the surgeon and also in the specific literature, as well as our clinical expertise to kind of foster you through that process. The programs that patients go through is 2 to 4 months, somewhere between 8 to 12, 8 to 16 weeks, as Dr. Kohrs alluded to. And very specific, very slow process of moving the shoulder passively to assisted and then onto resisted exercises. So common goals are obviously returning to your hobbies or lifestyles, your work, and or your sports activity. So moving to shoulder arthritis, as Dr. Kohrs noted as well, there's a couple of different forms of this. On the left, you'll see a different type of arthritis at the AC joint. You may have heard of this before, the acromioclavicular joint, and that's commonly bothered when you move your arm over your head and it kind of bumps up into your collarbone where it attaches to your shoulder blade. And then we have the arthritic shoulder where the glenohumeral joint is involved, the top of the humerus bone wears away, and we have problems there. So shoulder arthritis, the typical presentation for us in the PT clinic is limited motion. Commonly patients will tell us that it's catching or something's catching in there. We have a deep kind of a toothache feeling at rest. You may have done something and you go to sit back down and your shoulder starts to ache. So we kind of call it a toothache feeling in my shoulder. And then the popping and clicking comes from, as you've noted in the previous slide, where that rough joint at the top of the arm bone will bump on the shoulder bone, and you get that popping or clicking in there. So patients will say it kind of pops and clicks and it gets painful in there, so they can't move their arm all the way over their head or away from their body. And then consequently, we get some swelling in the joint from that. So it feels swollen and tight in there. That's because that bone's been popping and clicking and rubbing on the other bone and creates inflammation in there. So what's the treatment for this? So we try to start with some gentle range of motion. Getting that motion back to move appropriately is the main goal for everyone. So we start on the position of comfort. Sometimes that's even laying down. We start kind of anti-gravity. And then sometimes we'll have to use a pulley system to kind of help your arm move over your head. So we kind of sit and we use some pulleys to help your arm move very carefully and gently. And we can also help move your arm in the clinic as well and show you how to do that yourself with the goal of the muscles moving the joint efficiently. And the rationale, if all the muscles are working together, then the joint's going to move more appropriately. So the shoulder joint's a very complicated mover, and we try to get all those muscles to kind of help the arthritic joint to move better. We start with some light bands or light weights, and then we can move on as aggressively as we need to or as artfully as we need to. And then we move on to tennis elbow, lateral epicondylitis, as Dr. Kohrs noted. At your elbow, you have that tendon that's irritated right there where it hits the bone on the outside of your elbow, and it becomes irritated, inflamed, and it hurts. So we do the similar evaluation as we do on the shoulder. We ask you the same kind of questions. When does it hurt? How does it hurt? What do you do to help it? How long has it been bothering you? And we move forward from there, designing a program that's specific to you. If you work outside and heavy machinery, we work on a plan to help that. If you're a typist and you work on a computer, we'll help you with that kind of plan as well. So you see in this picture here on the left, just a diagram of what it may be, and then under a microscope. I always find it's important for patients to understand exactly what's going on, even at the cellular level, to know that there's damage to that tendon, that we need to help that, and we can do that conservatively with physical therapy. So tennis elbow, the presentation for us is similar to what Dr. Kohrs noted. We have the aching on the outside of the elbow at rest or with use. As we palpate on the elbow, we get some pain there, trouble gripping or shaking hands. Commonly, we do a simple test. We introduce ourselves to you in the clinic. We shake your hand, and that hurts. It's a pretty easy diagnosis at that point. As soon as we correlate that with poking right here, we pretty much know what's going on, especially with your history. So it's also trouble holding things like your coffee cup, turning a doorknob, a Coke can, things like that. Again, pretty simple evaluation, and then we can move on to some treatments. So typical treatment is that brace that, again, Dr. Kohrs alluded to as well. We use that right there to move the point of action of the tendon down into the muscle group, and so it takes the pressure off that tendon where it meets the bone, and that helps a lot. We control the inflammation conservatively in the PT clinic with ice. We teach you how to do that at home. We also teach you how to use massage to, again, move fluid where there isn't fluid. Dr. Kohrs mentioned that watershed point on the tendon. I do a technique called dry needling, myself and a handful of my colleagues. It's been shown in the literature to increase that blood flow and the fluid flow to that tendon. Again, as Dr. Kohrs alluded to, where that tendon gets dry and damaged, we can increase that blood flow and increase that fluid flow, similar to that PRP injection, without the blood draw and without the spinning down of the blood and re-injecting things. We use acupuncture needles. It's kind of a cousin to that to stimulate fluid flow and blood flow there to kind of help heal the tendon again. We can use some manual therapy techniques as well, which I do and my colleagues do, to loosen the muscle. So we take that brace off, we loosen the muscle that's become tightened because it's trying to help the tendon move better, so the muscle has to do extra work, and commonly will get bound up. We can use the needles in the muscle as well to loosen all that system and make things work more efficiently. And then finally, obviously, exercises. Once all that's calmed down, we use the brace and the needling if we need to, and we use the exercises to recondition the muscle and the tendon to work more efficiently and do the job that you need it to do for you. So in summary, we do a comprehensive evaluation. We spend about 45 to 60 minutes with you in the clinic, figuring out what we need to do and what you need for us to do. We set a common goal, a common plan of care, and we move on to the treatment plan based on those evaluation findings. And then we have a strong evidence-based intervention system at St. Elizabeth, and we use the literature to help guide our clinical reasoning to help you get where you need to be. Thank you very much for joining us tonight. I hope you learned a little bit more about the conservative care of the shoulder, and Dr. Kohrs and I have educated you on what you can do when you have problems with your shoulder and elbow. Thank you very much, and have a good evening.